from Kenya context. And again, you see lots of the BA.1 and the global BA.2. And again, you can see wrap up is our facility to report first entry of these waves variants, and also ability to share data with the global community, and also produce some of the work that went on to become really, really important, informing what was going on very early on, and really great collaborations by different groups across across Africa, largely led by the team in South Africa. Really fantastic work. So the other bit is training and capacity building. So this again has been really important early on to train other laboratories in the country and in the region to do SARS-CoV-2 sequencing. We've got a lot more centers in Kenya that are doing sequencing, and therefore again really contributing to a lot more genomes, and also building collaborations with other teams. PGI Africa, we're actually about to learn some interesting courses late in April, as well as other global consortium to advance capacity building in the country and across the region. And the other one is really great work through Africa CDC, WHO, Afro to support sequencing across the region. And that has been really great. We had lots of great support, first by the Ministry of Health here in Kenya, KEMRI, that's KEMRI Research Institute, where I work, Africa CDC enabling most of our work, TIBA here, really critical in seeding some of our very fast sequencing work, largely led by TIBA, and building on work that we were doing and establishing our platforms through the GEMV program, largely led by James Knox and at the University of Warwick, and really great, and glad for support from the Arctic Network, from the sequencing companies, being able to share their expertise and share reagents with them, and really great from my colleagues, in particular Charles Agoti and Isabella, with whom we run most of the genomics work, as well as a lot of support and mentorship from all these great scientists, and more important, really our sequencing team and the team from the Ministry of Health, as well as different teams involved in testing. Thank you very much, and bye.
Thank you very much, George, for this wonderful presentation. And I hope you still have some time to answer some questions.
Yeah.
Let me read the first question. Is from Lydia from Kemri, Nairobi. She says, which pipelines are you using for analysis and lineage calling?
We for the analysis, the wet lab, we largely using the Arctic protocol with particular modifications that allows us to sometimes have the reagents and really cut down costs. And that has been published. You should look at a paper by Arnold Labisia on that protocol, came out in Frontiers. And for the bioinformatics, again, relying very much on publicly available lineage calling pipeline, Pangolin, Nextclade, and Nextalign. If you're doing that bit of work, those has been really supportive.
All right. Thank you, George. The second question is from Kevin. He say, what is the effects of mixing vaccines in humans?
Well, yeah. So I'm a genomic epidemiologist, not a vaccinologist. So yeah, I can't answer that. Okay. It's slightly out of my area of expertise.
Okay. Let me go to the third question. Is from Opati. It says, from the look of the genetic tree, please explain the pattern of infections. Maybe I missed that part. So I don't know which phylogenetic tree, but I understand they are for different waves over time. So I don't know which phylogenetic tree is talking about. Yeah. Okay, let me go to this fourth question. Oh, it's in French. I think I need interpretation here. Okay, the fifth question. During the wave 5, I did not hear the reference number in relation to the reference genome. Could you please explain? That is still operative.
So sorry, what's the question again?
So the question is, during wave 5, I did not hear about the reference number in relation to reference genome. Could you please explain? So I don't know if it is clear to you.
Sorry, it's a little bit not very clear. Do you mean what the reference genome is? So when we're doing the alignment and the trees, we align the sequences in reference to the SARS-CoV-2 reference Wuhan isolate. Well, you can do that if you want to see this sort of diversity, and the trees that have generated have used that as the reference. And the other way to do it is that you can root your tree using some of the very early Omicron variants, if you like, and that can also provide you with some resolution in terms of the diversity. But again, it really depends on what the question really is, what you want to do.
Okay, so thank you, George, for that. There's a question from Anna. She is from Geneva, Geneva. So she says, what's your sampling strategy to select your sequence? Maybe you mentioned this, and I've also the same question on that.
Yeah, that's an interesting.
Go for that.
Yeah. Thank you. I think that's an interesting question again, and I'm going to go back to this cartoon that I was illustrating here. And what I've got to say is that some of the work is a little biased because we only sequenced what we're able to test. And the testing, again, is dependent on the policy on who to test. So, whether those are maybe travelers, when the return to work formulas came in, then individuals would need to be tested, and and therefore you get access to that. But the really important one is that if you get to be consistent, and even if you're sampling very few numbers, and you're doing that, trying to capture a relatively wide spatial region, you still can capture and understand what's going on, because the most prevalent lineages that are expanding, you're likely to get them. And that has been sort of the backbone of our surveillance. So if you look at the numbers, they are not much, but I can tell you that even if you sequenced all the genomes, all the cases, which I think is a waste of money, you will still, it's not going to change our sort of understanding. It can change your understanding of what's going on in particular localities. And that's why, for example, to understand the patterns of transmission within households, we've set up a household study where we're following over 140 households, trying to understand what the transmission dynamics are. And more important, we can use that to estimate secondary attack rates and so on. And also you can get a much finer resolution study like the health facility study that's led by Joyce, again, looking at what's going on within communities. And then you can, get your research questions a little bit more refined. But if you're looking at sort of what's global, sort of regional patterns, like what I'm showing here, even increasing the number of genomes is not going to change that. But your ability to test large number of samples can be important in capturing those very fast variants before they start to expand, and that's really important. So again, scaling genomic surveillance, I think, is something that we should encourage and we should continue to strive for and expand that within the country.
Okay. Next is from Yosef. He says, is it suitable to use vaccines manufactured in Kenya in a different country? That's over to you, George.
Yeah, again, I'm not in vaccine, but I mean, my understanding about vaccines is that they have to go through a number of stages, one that shows safety, their efficacy, and again, there's quite stringent policies around rolling them vaccines, and that there are universal and global rules about how you go about doing it. So as long as you follow that ethical process, as long as you follow the scientific process, I don't see why that will be a problem.
Okay.
But again, if there is a vaccinologist in the audience, you can take that up as well.
Okay, we'll see that. The next question, George, very informative. I wonder if these are Illuminaces or ONT, and thanks again for the great talk.
Thank you. So largely our backbone sequencing has been ONT, but we also have Illumina, and currently really keen to establish that as our secondary sequencing strategy. But most of what we've done relied largely on ONT, and that was really quick to set up and really great overall.
Okay. So again, a question from our party. It goes, were these samples selected randomly, or did you have a cutoff CT value for the study, and what was it?
Yeah, great. So the cutoff CT is around currently, we cut it at 34, and I didn't show that, but there's quite a good correlation between the CT value and genome coverage. So genomes or samples that have a CT value of less than 29 tend to give you better results in terms of genome coverage, and you can recover the full genome, whereas late CT or samples from late CT tend to give you not so complete genomes. But again, what you're looking at is a sequence that is correct and that can at least give you a phylogenetic signal, and overall sort of a cutoff of about 90 or 80 in terms of genome coverage can still be useful. The other important one from sort of a public health perspective, if you want to understand what lineages are going on, even a sample of at least 70% coverage can still be used by the existing tools to define what lineages are circulating. It may not be very great if your data is low quality to do some fine-grained analysis, phylogenomic analysis, but it can be sufficient to answer the question of what is circulating, what variants are circulating. But if it drops below 50%, it's pretty much crap, really. You're not going to answer most of those questions, and your data and lineage assignment is not very accurate, or might not be very accurate. As well as if you miss significant portions of the spike protein, it's particularly really important to be able to sequence the spike protein in its entirety, particularly with the sublineages that we find in Delta and now with Omicron.
Okay, so let me get it right, George. Is it random after establishing the proportion that you want to sequence?
So in a sense, you could, So in a sense, you could argue it's random because we're getting samples from particular localities in sort of, a convenient sampling, if I would say so, particularly for Kenya. And you could then randomize those data if you're interested in understanding and, getting some confidence intervals of what's circulating. But as I say, your sampling criteria is really dependent on your surveillance is really dependent on what you're able to test and what policies there are. And we know that in Kenya, we didn't have this sort of community sampling, regardless of whether you have symptoms or not. Mostly what you get are individuals presenting at the hospital or at a testing center for a secondary reason, whether that is travel or want to return to work, or the individual is sick, that's symptomatic, then those are the samples that you tend to get. So a lot of samples really go undetected, but based on those samples, we still can infer what are the most prevalent lineages that are circulating. But we may not be in a position to know each and every lineage that is in circulation. Nonetheless, if those sub-lineages take off, then it means they're going to infect a lot more people. Then if we are consistent with our sampling, with our genome sequencing, over time, temporarily, we're still going to infer or understand those particular variants. I don't know whether that answers your question.
It does. It does. So the next question is, at the moment, there's a new wave in Europe, but it seems the situation is different in the study in Africa. At least the figures you have shown. Can you please say a few things about this? That is from Theodros.
Yeah, thank you. So indeed, so if you look at how the pandemic unraveled across Africa, was very different from what we saw in Europe and what we saw in the Americas, and also what we saw in Asia. And at the moment, we're in a rather interesting position. So if you look at this wave here, the fifth wave, it was really a really large wave. And I think from our serosurveillance data, again, I can infer that a lot more people got exposed. And what I've not shown here is the number of individuals that have been vaccinated. So currently in Kenya, over 17 million people have had a COVID-19 vaccine. And don't know what proportion of that have had the boosters. So again, we got an interplay between a natural infection and vaccination, and that could be a major contributor as to why we might not see or very quickly see sort of a next epidemic. Nonetheless, sort of a really interesting epidemiological scenario, and I think it will unravel with time, as well as maybe some of our modeling work might be able to inform or infer how long does the community immunity last. And we know that we got quite an uptake of vaccine. Is still low. And previously, we know that a lot of SARS-CoV-2 infections were largely asymptomatic. And we know that a couple of individuals may have had exposure to other viruses, other corona-like virus, endemic coronaviruses, and that all can have an interplay in terms of how you respond to SARS-CoV-2. Quite a really interesting epidemiological scenario. We also know that the population pyramid is very different from what you see in Europe, for example. We got a really young population, and that has a significant effect on the number of cases and the disease and the pathogenesis of disease in Kenya. I don't know whether that answers you, but yeah.
Okay, so George, the questions are many, but I'll try to be fast. So someone asks, it's called Jabri, he says, to know the origin of wave 5 from your data.
Wants to know the origin of wave 5?
Wave 5, yeah.
Yeah, so the wave 5, we detected our first Omicron data from around mid-December. And again, these were individuals that had a history of travel to South Africa and to Ghana. And later on, retrospective sampling, as the wave panned out, we also saw that we may have had SARS-CoV-2 as early, or the Omicron variant circulating as early as mid-November. But then we see a real uptick of infections from December. We see this really rapid seeding of community transmission in December. And if you look at the tree, I didn't know whether I showed you the time tree or the divergence tree. This not be very, but you can see lots of cases are coming, and our genomes, Kenyan samples interspersed across global samples. So a lot of introductions coming in from other places. And again, if you know that within the period, there's the top seasonality for tourism in Kenya. It was coinciding with the holidays, and we didn't have a lot of restrictions. So again, sorry for moving you too much, but if I come down here, you can see in November, we were at the lowest in terms of restriction index. So very quickly, you can imagine how quick that wave panned out. But what is also interesting is that the number of deaths were fewer relative to what we registered during the Delta wave. That's wave 3 and 4.
Okay, let me take the next question. We have about 9 minutes to go. This is Richard. Fantastic talk, George, and thanks. Just wondering, is there any thoughts on as to the longer-term plan for SARS genomic surveillance in Kenya, flow surveillance platforms or other sentinel surveillance platforms that you really piggyback on? Over.
Good question. So again, we're working with regional bodies, Africa, CDC, WHO, Afro, strengthening our genomic capacity, and also collaborating with teams across the region and to ensure more training and capacity building. And also the Ministry of Health have been very critical in supporting the surveillance work and all the other stakeholders, and in particular within KEMRI, and expanding more testing or rather sequencing to other centers and other institutes in the country. So definitely I would see increased capacity to do this. But again, it's one thing to be able to sequence the genome. It's another thing to use those data to interpret what that genome sequence, its utility. And again, just to add that the genome sequence by itself is not very important. It's really, really critical that the associated metadata, that is associated with their sample is captured. For example, the date of sampling, the date of the sample, the vaccination status of the individual. We'd want to know a variant that may be breaking through vaccination, and also that may constitute or spreading within other localities. So again, the location of sample collection are really, really important. So the metadata is very important, and strengthening either centralization or coordination or collection of those metadata is critical to understanding and carrying out powerful genomic surveillance.
Okay, next is from Noah. He says, you have mentioned ATIC protocol. Can you please expand which one you're using for Illumina? Is it ATIC version 3 for COVID-19 and NEB, VASKIP, etc.? Are you also using the midnight protocol for anti-sequencing, and which version is that?
Yeah, so most of our work at the moment, we've been using ATIC Primer version 4. We just got moved to version 4.1. And for Illumina, we're setting up a COVID-SIG. That's still on I think version 4 primers. And we indeed got VASKIP primers. And that's important because we did see some dropouts among particularly the Omicron data set. So really important that, again, to capture the genome, and as a surveillance platform, we want to piggyback on multiple sequencing protocols, just so that then we can capture underlying diversity and ability to get the full genome. But we have largely relied on version 4, and one of the challenges, and I think that a lot of people in Africa is timely receiving of sequencing reagents. So it's one thing to release a fix to an existing protocol. For example, we know from version 3 of ATIC primers to version 4 and to version 4.1, and placing an order that takes time. And before you get your reagents, it's 3 months down the line, and you got to keep sequencing at the same time. Acknowledge that delay in procurement, and again, shortage of particular reagents in the global market. Again, all impacting on Africa. And some more important is, very early on, cessation of movement, lack of travel. Again, means that you can't get reagents on time because they all rely on those chains of transport to be able to get those those reagents. Yeah.
Okay, I'm taking the final question. It's from Dagim from Ethiopia. It says, great presentation. Do you think these findings and insights can be attributable to other neighboring countries? Any similarities? Over.
So sorry, I didn't get that.
So he's asking whether these findings from Kenya can be extrapolated to other neighboring countries.
Yes, indeed. So particularly for the countries that we work in, Ethiopia being one of them, really, we've been working very, very closely, and we can do sort of similar analysis. And for those that we've provided sequencing for, we've been able to, show that information and even publish some of the work. And therefore, whereas maybe the patterns may differ, the technology and the capacity to do that can be expanded, and we can leverage on platforms like Africa PGI. They can provide training, and now we got a number of countries starting on the 28th that will be visiting, supported by WHO, to come and do or learn sequencing with us, and then go on and carry out sequencing in their countries. So really keen to carry out that support. And again, very closely with Africa PGI, we'll be running training largely targeting East Africans, and that's the countries around East Africa on genome surveillance, analysis using SNAKEMAKE, for example, to support the analysis that the kind of figures that you saw me producing. And there are other institutions and I think a lot of support, across the continent, really, if you want to engage with them. But yeah, you can write to me or write to Gerard, and we can, speak a lot more on that.
Excellent. Thank you once again, George, for taking time to present to us about the genomic surveillance of SARS-CoV in Kenya. I would like to close today's webinar, but the next webinar will be on 29th March, and the presenter will be Dr. Emma Handicroft from University of Bern, and from promise to practice phylogenetics in and beyond the pandemic. So that will be a Tuesday, not Wednesday. So please join us then, and thank you very much. Have a nice day. Bye-bye.
Bye. Thank you.
Welcome.